will start out. Good morning to everyone. It's a great pleasure for me, on behalf of Norwegian School of Sports Sciences, to welcome you all to this trial lecture in partial fulfillment of the requirements of the award of Doctor of Philosophy in Sports Science. My name is Lone Friis-Ting. I'm head of department, and I will chair the two sessions here today. In particular, I would like to welcome the members of the examination committee. First, the chairperson, Associate Professor Julie Sørbø Stang, Norwegian School of Sports Sciences. The first opponent is Principal Researcher Dr. Tuija Tamelin, Jyväskylä, University of Applied Sciences from Finland. And the second opponent, Professor Jos Twisk, Amsterdam University Medical Centers from the Netherlands. Furthermore, I would like to welcome the candidate, Anders Husøy, who will give the following lecture with the title, How to Decrease Sedentary Behavior Among Older Adults. Indeed, over to you, Anders.
Welcome to my trial lecture. I would like to start by thanking the committee for both an interesting and challenging task. So let's jump right to it. Or maybe not. Let's see if I can. There it is. Okay. So this is the topic that I was given, how to decrease sedentary behavior among older adults. The lecture will follow this outline step by step. I will start with some definitions and the literature search before examining how sedentary older adults are, what the consequences of excessive sedentary time is, what leads to sedentary behavior, the effect of intervention studies on decreasing sedentary time, and guidelines and action plans. Hopefully, by the end, we will come closer to an answer. Let us start with some definitions, namely the terms sedentary behavior and older adults. Sedentary behavior is commonly defined as any waking behavior characterized by an energy expenditure of 1.5 metabolic equivalent, or METs, or less, while in a sitting, reclining, or lying position. This could be TV viewing, playing video games, computer use, driving, or reading. For those of you who don't know the term MET, it's defined as the resting metabolic rate, or the amount of oxygen consumed at rest. As such, physical activity at 2 METs require twice the resting metabolism, and so on. Sedentary behavior is typically measured through either self-report or device-based measures. Self-report tend to overestimate physical activity and underestimate sedentary time. Device-based technologies such as accelerometers offer opportunities of more precise measurements of physical activity and sedentary time. I would also like to define terms that are related to sedentary behavior, but yet different. This is the definition of sedentary behavior we saw on the last slide, and many confuse this as the same as physical inactivity. However, physical inactivity is an insufficient physical activity level to meet present physical activity recommendations. That means that physical inactivity is not being sedentary, it's being insufficiently active. And physical activity is any bodily movement produced by skeletal muscles that require energy expenditure, usually subcategorized into light physical activity, moderate physical activity, and vigorous physical activity. The relationship between these terms can be exemplified through this figure. As we can see here, sedentary time is, for our typical sedentary activities can be TV viewing and sitting, and is spending time in this purple or orange area. Physical activity, on the other hand, is failure to spend enough time in these yellow and green areas, while physical activity is time spent in any of the blue, yellow, or green areas. So on to older adults. Older adults is a wide term and a segment of the population with a lot of diversity. For the ease of this lecture, I have made the following delimitations to the term older adults. Individuals aged 65 years or older, no clinical conditions hindering physical movement, and living at home. I would also like to do a quick walkthrough of the literature search performed to give an indication of the theoretical foundation for this trial lecture. The first literature search I performed returned tens of thousands of hits. Therefore, I split the search in 3 and combined them afterwards. The first search string focused on sedentary behavior among older people. The second search string focused on decreasing sedentary behavior. And the third search string focused on correlates or determinants for sedentary behavior among older adults. And correlates and determinants means factors that lead to or are associated with sedentary behavior. Due to the large number of hits, a restriction to systematic reviews was also made. The combined search returned 240 hits, with 3 records retrieved from other sources. And after removal of duplicates and a screening process of the titles and abstracts, 57 systematic reviews were left regarding the topic of sedentary behavior among older adults. Of these, most focused on sedentary behavior and health outcomes, and then in descending order, intervention effects, correlates and determinants, levels of sedentary behavior, and guidelines and action plans. So, first and foremost, to what extent is sedentary behavior among older adults a problem? Are they sedentary? Older adults are widely reported to be the most sedentary and the least active segment of the population, engaging in an average of about 9.5 hours of sedentary behaviors per day. It has also been reported that changes in sedentary behaviors have been observed across the retirement transition, which in many countries is around 65 years of age, with increases in duration, prevalence, and frequency of sedentary time. Prior studies also indicate that particularly the oldest old, which means 80 years or older, are highly sedentary. Several of the Nordic countries have implemented a national surveillance system of physical activity and sedentary time using device-based measures. In Norway, these are called the UngKan studies. The first one was carried out in 2008-2009, the second one in 2014-2015, and the last UngKan-3 had the data collection in 2019 to 2022. And I would like to show some data from UngKan-3. Here we can see a bar plot of average sedentary time as minutes per day among Norwegian adults by sex and in different age groups. These are so-called estimated marginal means, which are adjusted for mean wear time and wear month of the accelerometer. As we can see here, among both sexes, older adults do spend a little more time sedentary than younger adults, but the difference is not big, about 15 minutes per day. However, the age group of 65 plus is highly diverse, which means that you may expect a 65-year-old, a 75-year-old, an 85-year-old, and so on to differ in terms of sedentary behavior. Therefore, a comparison was also made, combining the age groups of 20 to 64, and then dividing the 65 plus group into 5-year intervals. Now, the picture gets slightly more nuanced, but we should also make note of the relatively small number of participants in the oldest age groups, which is particularly true among men. Notwithstanding that, a clear pattern emerges where we can see an increase of the average time spent sedentary with increasing age among both sexes. For both men and women, the oldest age group, aged 80 years or older, spend over an hour per day more sedentary than adults aged 20 to 64. So, by now we have established that older adults probably spend more time sedentary than younger people, and particularly the oldest age groups. But is this a problem? What are the consequences of sedentary behavior? Sedentary behavior has been associated to a wide range of adverse health outcomes, and these includes cardiovascular, cancer, and all-cause mortality, incidence of cardiovascular diseases, cancer, and type 2 diabetes mellitus, obesity, reduced physical fitness, reduced mental health, reduced cognitive function, sarcopenia, reduced quality of life, reduced physical independence, frailty, and reduced bone health. Some research have suggested that the risks associated with sedentary behaviors are independent of the amount of physical activity, both among the older and the younger adult population. However, a harmonized meta-analysis with over 1 million people concluded that sufficient time spent in physical activity of at least moderate intensity can attenuate or even eliminate the hazards of sedentary time. However, the highest quartile in this study, or those most active in this study, did spend between 60 and 75 minutes per day of at least moderate intensity physical activity, which in turn may be feasible for only a subset of the older population, which means that excessive time spent sedentary likely will have detrimental health effects for most older adults. So what's the economic burden of sedentary behavior? The economic burden of physical inactivity, that is, being insufficiently physically active, is well established. However, less is known about the economic costs of excessive sedentary behavior. A recent systematic review from 2022 concluded that sedentary behavior is likely associated with excess healthcare costs, but the evidence is limited. However, I did find 2 studies published after this review. One is from Finland, from the Finnish population, where estimates suggest that costs attributable to sedentary behavior were roughly 1.5 billion euros in 2017. Another one is from Canada, where Canadian estimates suggest that the total costs of excessive sedentary behavior was between $1.8 and $2.2 billion in 2021. At this point, we have established both that older adults do spend a lot of time sedentary, and that sedentary behavior is associated with a range of adverse health outcomes and likely also a substantial economic burden to society. But why are older adults sedentary? To answer this question, I looked for correlates and determinants in the literature, and I found a total of 8 relevant systematic reviews. However, only three of these specifically examined correlates, predictors, or determinants of sedentary behavior among older adults. More than that, most of these studies were of cross-sectional design, and thus ruling out causality. With a cross-sectional design, the exposure and outcome are measured at the same time. Thus, it's impossible to determine whether change in exposure leads to change in the outcome, or if it's the other way around. Furthermore, other factors potentially affecting this association, such as confounders, cannot be ruled out by this study design. However, they can be used to form new hypotheses and be exploratory. Here we can see a bubble plot of some potential correlates of sedentary behavior, with the size of the bubbles increasing by the frequency of mentions they have in the literature, and then combined into broader groups. Demographic factors are the most frequent correlates of sedentary behavior, which includes increasing age, gender, and then specifically male, marital status, and then specifically unmarried, and employment and retirement status. The others here may be more self-explanatory, and we can see that factors such as socioeconomic status, opportunities in the environment, social aspects, previous behaviors, health condition, and physical functioning all have been found to correlate with sedentary behavior among older adults to varying degree. While causality cannot be inferred from this, it may provide information for future research and intervention studies. Another interesting perspective would be how sedentary behavior is perceived among older adults. A quite recent systematic review from 2019 did a thematic synthesis of qualitative studies and found a lack of either knowledge on or awareness of sedentary behavior among older adults. Most older adults confuse the terms sedentary behavior and physical inactivity. And more than that, they lacked knowledge on health consequences of extensive sitting. Furthermore, it seemed that sedentary behavior was firmly incorporated into older adults' routine, which could mean that there's a habitual nature to sedentary behavior. And last but not least, older adults reported to associate sedentary behaviors with both enjoyment and comfort. And that was enjoyment both of doing the activities, such as watching TV and sewing, and the social aspects of the activities, such as going to restaurants and card playing afternoons. They also reported to engage in sedentary activities out of convenience and comfort. So, older adults are the most sedentary segment in the population, and the negative health consequences of excessive time spent sedentary are established. Several factors correlate with sedentary behavior, but it may seem that knowledge about the dangers of sedentary behavior could be better, while many older adults associate sedentary behaviors with both enjoyment and comfort. This in turn could make interventions to reduce sedentary behavior challenging. Let's examine how effective previous interventions have been in decreasing sedentary behavior among older adults. So, these interventions targeted sedentary behavior using a wide range of strategies designed to reduce sedentary time at work, within the home, whilst traveling, or during leisure time. I found a total of 8 systematic reviews specifically examining intervention effects on sedentary behavior among older adults. However, the vast majority of these studies use self-reported measures of sedentary time. And due to the vast number of studies, I did a screening for randomized controlled trials, or RCTs, using device-based measures of sedentary time. And because the between-study definitions of older adults varied quite a lot, I also included studies where the average age was at least 65 years, and no participants younger than 55 years of age were included. A total of 7 RCTs fit these criteria, and they also provide the data needed for a meta-analysis. A meta-analysis is a summary or a pooling of results across several studies. Here we can see the 7 included studies at the left-hand side, along with the length of follow-up, the percentage of the sample that were women, and the number in the intervention and control groups. In total, there were 502 participants in the intervention groups and 511 participants in the control groups. In the middle here, we can see the results from each individual study. If the results is to the left of the vertical black line in the middle, the result favors the intervention. If it's to the right, the result favors control. At the bottom, we can see the results from all of these studies combined. we can see that the average effect of the intervention studies lies slightly to the left, with a reduction in sedentary time of 22 minutes per day at follow-up. However, the confidence interval, which is a measure of precision or uncertainty, cannot exclude the possibility that these interventions had no effect. Furthermore, the meta-analysis indicate a large degree of what is called heterogeneity, which means that the variability in effect sizes between studies is large. The prediction interval, which is the red line at the bottom, takes this heterogeneity into account and indicate that the uncertainty surrounding these results is large. Of note, the follow-up time here is the longest follow-up time reported and not necessarily corresponding with the length of intervention. As we can see, particularly the study by Harris and colleagues sticks out with a follow-up time of 4 years. While they did not find any difference in sedentary time, they concluded that physical activity level was still increased 4 years after baseline. Of note as well, in most of these studies, they found it hard both to recruit and keep men in the interventions, exemplified by the high proportion of women ranging from 54% and all the way up to 87%. So, what characterizes these interventions? You can see here that 2 of them implemented a walking program. One delivered an exercise program via DVD for them to do at home. Other focused on workshop sessions on physical activity for education of the advantages of physical activity. There was also web-based interventions based on theories and principles of change in behavior. Some delivered an active guide brochure, once again focusing on educating the participants. And one focused on a combination of written materials, in-person health coaching sessions, and follow-up health coaching phone calls. As you may notice, almost all of these focuses some way or another on increasing physical activity rather than decreasing sedentary behavior, although sedentary behavior is an outcome of interest in these studies. I think it is time we revisited the relationship between sedentary behavior and physical activity at this time point. As we may remember, sedentary behavior is activities in a sitting, reclining, or lying position with an energy expenditure of 1.5 times the resting metabolism or less. However, at all waking hours, we are spending all our time in one of these 4 categories, often referred to as the energy expenditure continuum. That means that time decreased in sedentary behavior doesn't just disappear, it needs to go somewhere else. In this case, physical activity of any intensity. So, in that sense, decreasing sedentary time equals increasing time in physical activity. It came to my mind when I saw the trouble of recruiting and keeping older men in these intervention studies that I had seen this before in my time in cancer research at Oslo University Hospital. It was well known among the clinicians that older men, and then specifically prostate patients, were chronically hard to recruit as compared to the breast cancer patients. The intervention studies in cancer research often involved activities such as walking, yoga, group-based strength exercises, and so on. In Denmark, however, they did a study called FC Prostata, or FC Prostate, which I would like to show a short video of. I have tried to add English subtitle to the Danish language, which unfortunately I'm not fluent in. But let's try.
Alle tager en bold, så man har en bold hver især. I kender øvelsen. Dribler ind imellem hinanden.
Jeg har faktisk kun spillet fodbold som knægt, Og så lige pludselig, så kommer det her. Og det kan man nok se, tror jeg.
FC Prostata spiller på den her bane. Det er mænd, der er blevet konstateret prostatakræft. Og de er en alder, der hedder fra 59 til 78 år. Og de spiller 3 gange ugentligt. Krop ned, så vi lige snitter bolden. Og op og stå igen, strækker benene. Kommer lige ned og sidder. Det er ondt, vi bliver filmet nu. Vi løber videre.
Jeg har aldrig spillet fodbold, men jeg har begyndt at lære det. Jeg glæder mig til at komme hen hver gang. Det tager 6,5 timer med tog, fra jeg tager hjemmefra til at komme hjem igen. Men jeg glæder mig til at komme hen hver gang.
Tager en tår vand, og så skal vi ellers stille op til noget fodbold her.
Vi har jo et fællesskab med, at vi har den samme sygdom og får den samme medicin. Og den medicin, den har jo som sagt mange bivirkninger. Og vi snakker jo også om vores sygdom og altså de bivirkninger, vi har hver især, og udveksler erfaringer. Og det er rigtig godt.
Yes. Jeg så lige et hul.
Fysisk tror jeg, at det har betydet, at jeg har fået en bedre vejrtrækning. Jeg har fået lidt mere på benene, lidt muskler. Og så tror jeg også, at jeg har taget lidt af i vægten. Og det kunne jeg nok trænge til.
Grøn går dernede, og hvid bliver her. Ude på fodboldbanen er de blevet meget mere mobile. De har mange flere kræfter, og deres fodboldmæssige færdigheder er også blevet forbedret. Så det er rigtig, rigtig godt at se.
Vi skal bare have en til at stå bag. Jeg står bag os i starten. Kom, vi kører.
Vi håber på, at mændene her bliver rigtig glade for at spille fodbold, at det er noget, de fortsat har lyst til. Hvor kvinder måske i højere grad kan lide at sidde og snakke over en kop kaffe, jamen, så tror vi på, at mændene de har det sjovere med at komme ud og spille lidt fodbold. Og dermed måske kan de også begynde at åbne sig og snakke om deres sygdomme.
Yeah!
Ole! Ej, det er godt lavet, mand.
Ja, godt ud. Så er det altså flinke folk, som ikke takler unødigt, så man får kun lidt blåmærker.
Vi holder pause.
4-1 tror jeg til de andre, desværre. Ja, den kommer igen.
Og pause.
Jamen, jeg har tænkt at udmatte ham.
Trygfonden vil gerne støtte FC Prostata, fordi der er nogle rigtig gode perspektiver i det til den her gruppe af patienter, fordi at det tiltaler mænd, det her fodboldkoncept. Det tiltaler dels de fysiske aktivitet, konkurrenceelementet og den måde, man socialt er sammen omkring fodbold. Det er noget, der tiltaler mænd, og det passer dem.
Nej, den gik ikke mæssigt.
Hvad er din taktik, siden du kan score så mange mål?
Jeg var heldig. Han lusker rundt nede ved vores mål, gør han. Det er det, han gør, i stedet for at bevæge sig rundt på banen.
I fredags, da du ikke var der, så den bold, den kom lige om, og så gik den lige ned herunder der. Det var skide godt. Det er det bedste mål, jeg har lavet nogensinde.
Det er ikke noget, de er lige gode alle sammen.
Ja, det er klart for helvede. Ja, vi spiller for en anden sags skyld, ikke?
Må jeg skulle tage fat, drenge?
While I recognize that these men belong to a specific clinical subpopulation, it is an example of someone who went about it a little differently in terms of intervention design, and successfully so. The reports from this study were a low dropout rate and comparable health effects to doing interval training. It also embodies the importance of joy of movement and the social aspects of being competitive together in a team sport. Maybe we sometimes design intervention with more of a focus on effectiveness rather than the joy of movement, when maybe it's possible to get both. I just wanted to show this video as a short success story. I will try not to get sidetracked too much. So let's move on. We're nearing the last part of this lecture, and we have established that older adults spend much time sedentary, and that this is associated with a range of adverse health outcomes. Furthermore, we have seen that some correlates to sedentary behavior exist, but that the intervention effects of previous studies have been largely varying. Given the health hazards of sedentary behavior, what are the guidelines for spending time sedentary, and how are we aiming to implement these? These are the global recommendations on sedentary behavior by the World Health Organization, published in 2020, which are divided in two. Older adults should limit the amount of time spent sedentary, replacing sedentary time with physical activity of any intensity, including light intensity, provides health benefits. And number 2, to help reduce the detrimental effects of high levels of sedentary behavior on health, older adults should aim to do more than the recommended levels of moderate to vigorous intensity physical activity. We can clearly see from these recommendations that sedentary behavior and physical activity is closely related. It would also make sense at this point to show the guidelines on physical activity for older adults. All older adults should undertake regular physical activity. Older adults should do at least 150 to 300 minutes of moderate intensity aerobic physical activity, or at least 75 to 150 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous intensity activity throughout the week for substantial health benefits. Older adults should also do muscle strengthening activities at moderate or greater intensity that involve all major muscle groups on 2 or more days a week, as these provide additional health benefits. As part of their weekly physical activity, older adults should do varied multi-component physical activity that emphasizes functional balance and strength training at moderate or greater intensity on 3 or more days a week, to enhance functional capacity and to prevent falls. Older adults may increase moderate intensity aerobic physical activity to more than 300 minutes or do more than 150 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate and vigorous intensity activity throughout the week for additional health benefits. The WHO also have some good practice statements for older adults, and these includes doing some physical activity is better than doing none. If older adults are not meeting the recommendations, doing some physical activity will bring benefits to health. Older adults should start by doing small amounts of physical activity and gradually increase the frequency, intensity, and duration over time. And older adults should be as physically active as their functional ability allows, and adjust their level of effort for physical activity relative to the level of fitness. Once again, we can see how tightly intertwined sedentary behavior and physical activity are, which is also exemplified by this figure, which illustrates that more physical activity is needed to attenuate the hazards of sedentary behavior if we spend a lot of time sedentary. We want to be in the green part of this figure. So if we spend a lot of time sedentary, we have to do a lot of physical activity to get into the green area. If we spend less time sedentary, we have to do less physical activity to get into this green area. So, what is being done to implement these guidelines? In Norway, we have an official action plan from the government on physical activity in the period of 2020 to 2029. In both this document and particularly in the global recommendations by the WHO, a special focus is devoted to dissemination and implementation of the guidelines. And in this context, dissemination means purposive distribution, and implementation means actions supporting the population in reaching the recommendations. However, a recent systematic review found limited information about the dissemination and implementation of national guidelines, and the strategies were rarely evaluated. Furthermore, the systematic review concluded that low guideline awareness and knowledge could be expected if previously used guideline dissemination strategies were followed. They also concluded that greater efforts are required to increase the impact of guidelines among the members of both the general public and stakeholders, and to build the evidence base. So, I've come to the point where I would like to conclude. What can be done to decrease sedentary behavior among older adults? Exercise is Medicine is a global health initiative managed by ACSM, aiming to make physical activity assessment and promotion a standard in clinical care. The Norwegian group is interdisciplinary and includes doctors, health and exercise physiologists, physiotherapists, and scientists. They have recently pitched suggestions on how to facilitate more physical activity as prevention in the healthcare service to the Ministry of Health and Care Services in Norway, where some are relevant for the topic of this trial lecture. Based on what we have learned here today and the suggestions from Exercises Medicine Norway, the following measures may be of help in decreasing sedentary behavior among older adults. Number 1. Educating healthcare personnel. This involves increased emphasis on educating healthcare personnel in the advantages of reducing sedentary behavior and increasing physical activity, and the use of tools such as motivational interviews to promote behavioral change. Medical doctors, for example, have only 2 times 45 minutes involving physical activity and health in their medical education at the University of Oslo, and it is not part of their exam curriculum. Older adults will likely see their GP more often, especially with increasing age, and this could be a suitable arena for increasing knowledge about physical activity and sedentary behavior. Healthcare personnel who have a solid understanding of how physical activity affects health will be better equipped to guide and support patients in integrating more activity into their everyday life. Number 2, increased and improved collaboration between healthcare professionals. This suggestion involves increasing cooperation between health services and professional groups by implementing new forms of cooperation to integrate physical activity as a central part of patient treatment, involving groups such as medical doctors, physiotherapists, and health and exercise physiologists. A safe and effective exchange is necessary when the responsibility for patient follow-up is moved between GPs, hospitals, physiotherapists, and healthy life centers. Today, these institutions can be located close to each other without having any contact. Additionally, digital health guidance can be part of this solution. Digital services can increase accessibility for patients who do not have or do not want to participate in physical services. Number 3, group-based interventions. Such interventions can be offered as part of the primary healthcare service in addition to digital follow-up services to ensure continuity of treatment. Additionally, group-based measures add valuable social interaction, which is important for the experience of meaning and mastery, motivation, and general health, like we saw in the video clip earlier in the lecture. Group-based sessions can be organized in GP offices, in local communities, in sports teams, or in workplaces to provide social support and increase motivation among patients. Once again, interdisciplinary collaboration between healthcare personnel should be promoted to ensure integrated care. Number 4, physical activity in elderly care. This includes promotion of physical activity, especially strength training, as a central measure in elderly care to improve the functional health of older people and contribute to more people being able to live at home for longer. Muscle strength is essential and the most important limiting factor for the elderly in carrying out the tasks of daily life. Reduced physical fitness is both a cause of and a consequence of aging and disease, and physical activity, especially strength training, is essential for maintaining muscle strength, balance, and general functional ability in the elderly. This initiative involves the establishment of dedicated training arenas for the elderly with qualified personnel, such as physiotherapists and health and exercise physiologists, as well as the integration of training programs in old age and nursing homes. And number 5, a National Digital Physical Activity Parameter, or PAI. PAI stands for Personal Activity Intelligence, which is a technology developed in Norway. It's a scientific and validated tool that measures physical activity based on heart frequency. And this in turn provides a physical activity score. A score of 100 and more is associated with lower risk of CVD mortality. This index can be measured directly by any kind of heart rate monitor or estimated by logging physical activity. Furthermore, this measurement can be integrated into electronic health records and the national health platform helsenorge.no, and would enable healthcare professionals to both monitor and promote physical activity in a systematic way. While there may be no definitive correct answers to the topic of this trial lecture, these measures may, both individually and synergistically, help in decreasing sedentary behavior among older adults. Thank you for your attention. Okay.
I thank the candidate, Anders, for his lecture and invite everybody to return to the auditorium at 1 o'clock. Provided that the examination committee finds the trial lecture acceptable, the candidate will then defend his thesis. So, thank you for now.